Hi everybody and welcome. This presentation is based on an improvement project that is focused on delayed discharges and discharge planning in the after-hours space. This presentation will outline the associated organisation-wide issues with quality and safety when faced with suboptimal discharge planning, and it will also focus on strategic solutions to address this using the PDSA cycles. There is significant correlation between the reduction of adverse events, increase in patient safety and risk mitigation as a result of efficient patient flow, and this project aims to synthesize all of these elements for improved results spanning the overall facility performance. The foundation of patient flow is efficient and successful discharges planned and completed early for admitted patients, whereby capacity is created throughout the hospital. However, we often face severe ED overcrowding and bed block, leading to critical compromise across the facility. Ambulances are unable to offload, theatre cases are prevented from going ahead, and emergency treatment is delayed. This equates to an unsustainable level of risk management and risk control for emergency department staff. The literature outlines a plethora of issues associated with ED overcrowding, including risk of delayed medical treatment and poorer associated outcomes. The literature additionally illustrates that patients sustain greater risk to their health when lengthy hours are endured in ED, demonstrating higher rates of hospital-acquired injuries. This can include delirium, pressure injuries, falls, infection, and a longer length of stay for the total admission due to delayed diagnosis and treatment. A longer length of stay in ED means a longer admission and higher risk of harm, with a parallel increase in hospital expenditure to support patient episodes of care. This incurs one of the highest operational costs and resource use, further contributing to the impediment of efficient patient flow and quality care and safety for these patient cohorts. There is significance to the process of discharge planning as a round-the-clock service of the hospital. This project aims to optimise formation and completion of discharge planning occurring throughout all 3 shifts in a 24-hour period, guided by additional stepped processes during after hours. Day of discharges leads to an additional pressure and responsibility on medical and nursing staff to expedite those discharges within a shift that already faces a multitude of pressures, demands, and tasks to be done. This project can reduce the business hours operations demand and allow the distribution of responsibility to be shared across all staff and all shifts. It prevents communication failures, missed care, and omitted tasks, and improves patient satisfaction with their discharge planning, particularly when patients are prepared and expecting to leave. Premature discharges lead to heightened patient vulnerability, peri- and post-hospitalisation, which can lead to greater morbidity and mortality and readmission risk. The literature emphasises the imperative of resourceful, safe, and planned discharges to prevent negative repercussions. The project will involve presiding a good-to-go huddle at 3 p.m. each day on the selected wards, comprising of the ward NUM, nursing team leader, registrars of specialist teams, and allied health representatives of the ward. It will be a discharge positive round, allocating 15 minutes for resolute discussion. Its purpose to follow up the morning round, where patients who are good to go the following day are re-identified and reprioritization of outstanding items for their discharge are discussed and actioned. The literature conceives several successful variations of afternoon discharge huddles, evidencing improved patient flow and following day early discharge, without burdening staff with extra workload or implicating patient quality care. This will then be sequenced by an 11 p.m. rapid round. The night shift nursing team leader will highlight and discuss in unison with the night shift physician any actions that can be expedited that's not specialist dependent to ensure patients are prepared for the following day release. Such actions may include ordering or completing early venipuncture and pathology, ordering or completion of discharge scripts, internal online referrals, examining in imaging and other results, and initiating early trial of voids. The nurse team leader would oversee the delegation of completing transfer letters and nursing care summaries, ordering early breakfasts, completion of discharge checklists, and preparing a handover that summarises the discharge actions in the morning. This concedes timely return of intervention results and prevents late evening discharges. Literature limitation exists to the efficiency of discharge-focused communication occurring after hours. However, a 2021 quality improvement study concluded culpable impact on following day expedited discharges, accredited to the night shift stakeholders proactively collaborating and engaging with the project. With applying the Model for Improvement and Plan, Do, Study, Act (PDSA) cycles, this methodology will be pertinent in reviewing and adapting applied strategies to work towards the best outcomes. The operational context of applying this tool enables the assembly of a dedicated team closely monitoring the results and strategizing the critical incremental steps to achieve the desired results. The project will be facilitated by the patient flow team in unison with the medical workforce, allied health, nurse managers, and nursing team leaders of 2 dedicated medical wards. With working through the PDSA cycles and refining the project, this strategy can be rolled out to expansion across the facility. The PDSA Cycle 1 planning stage involves assembling the team led by patient flow with relevant nursing staff, management, and medical teams and allied health. The team will need to observe the current processes for discharge planning and gain an understanding of any afternoon and night shift processes which can enhance discharge readiness for the following day. Communication and buy-in will be next to engage with the relevant stakeholders, including the development of promotive material and targeted education. The development of a timeline will also require creation to allow feedback at the conclusion of each cycle. Review and reform of the discharge checklist is also an essential item for team leaders and night physicians to refer to once the project goes live. And finally, collection of pre-existing pre-project data for comparative purposes, including discharge percentage of patients exiting the facility by 10 a.m. and ED long length of stays. As part of Cycle 1, Do strategies include go live broadcasting in place to ensure thorough dissemination of information, the patient flow team attending and monitoring morning discharge rounds and good to go 3 p.m. rounds to assist and guide in standardizing the meetings. This will also correlate with stakeholders attending and fostering ongoing education to support the delivery of discharge planning, receiving feedback and assessment of the night shift 11 p.m. round, and the ward NUMS and patient flow team to collate ongoing data. Cycle 1 study strategies include following the timeline of implemented feedback dates, chairing feedback meetings to ensure the project is being received, implemented, and analysed. Patient flow are to continue to engage with multidisciplinary teams to receive suggestions and propose regime changes. And a data review will be able to assess any tangible change. This will test the hypothesis of increasing early timing and amount of discharges occurring before 10 a.m. and correlation with decreasing bed block and reduced overcrowding in emergency. Cycle 1 strategies include the patient flow team confirming proposed updates and changes to good to go huddles and 11 p.m. rapid rounds, planning for the next PDSA cycle to implement any changes or reforms to the project, reiteration and education for discharge strategies with standardized and strong messaging to increase sustainability and retention of the project, conducting orientation to new team members or rotational staff, and refining the project to initiate across other medical wards. The first PDSA cycle would be conducted over a 4-week period with incremental steps changes to occur within that small sample cohort. Variables and trending patterns can be captured in a 4-week period to ascertain the efficiency of the project, seeking swift results with discharge times and rates. The outcome measures for this project for the first cycle will be based upon improvement in the discharge data and looking at discharges occurring before 10 a.m. As a result of improved discharge planning occurring across all shifts of the day, the project would hope to see an increase to the total number of discharges and a percentage of that amount occurring earlier when compared with the comparative historical data. This is based on robust and organised preparation to facilitate safe transition out of acute care. The PDSA cycle would anticipate that bed block is prevented earlier in the day with an upstream effect for the following shifts as a result of coordinated discharge planning. Literature reiterates the cause and effect of delayed discharges with emergency department overcrowding. The effectiveness of this would see measurable results in the reduction of emergency department overcrowded, calculated by the instance of the facility step level per day, producing a greater availability for ambulance offloads and walk-in patients. This can decrease delays in emergency for delivery of care and context of care and prevent the associated risks with quality patient safety. In a broader context, the risk mitigation for ED patients through this project can lower patient exposure and incidence to adverse events and hospital-acquired injuries, and thus decrease organisational costs, which can also be stipulated as an outcome measure on an organisational scale when analysing large sample data. Continuity of care and discharge planning throughout all 3 shifts of hospital services in a day is an integral part of delivering quality care to patients and ensuring patient safety pre- and post-hospitalisation. With the implementation of this model for improvement to bring discharge planning to the forefront of all hospital stakeholders after hours, the streamlining and optimisation of discharges can prevent delays on the day of discharge as endorsed by the literature. Using the PDSA cycles to enact this project can facilitate refining discharge processes and ultimately catalyse successful outcomes in the prevention of emergency department overcrowding, prevention of hospital-acquired injury, and early access to patient flow to provide the correct context of care to all admitted emergency patients. Thank you.